So this PowerPoint presentation is on the musculoskeletal disorders of the pediatric patient. I suggest, since there's several different disorders here, that you do part of it one day and do your notes, and then do the second half the next day and do your notes, so that it kind of isn't too much at one time. This is, as all of them are, really important in peds, and these are things that happen only in children. I hope it's clear for you. So our outcomes mainly is to identify each one of the disorders, understand what they are, and be able to discuss the treatments and the nursing care. We're starting with clubfoot, or talipes equinovus. Actually, there's 4 different kinds of club feet that the child could have, and all of it is in Latin. Each name is in Latin, and it describes what the foot looks like. But in general, we're talking about a deformity of the ankle and foot involving the bone deformity, and it's malpositioned, and we see soft tissue contracture. The actual foot, when the baby is born, actually is twisted so that the sole of the foot is either facing sideways or upside down. And here's 2 pictures of it. Contributing factors is generally intrauterine crowding. It's just positional, how the baby's feet are laying in the uterus. It can be tacked on to other disorders, such as cerebral palsy. It can be hereditary, but more than half of the children have idiopathic clubfoot. It can be seen in prenatal ultrasound, and it's definitely visible at birth. When x-rays are done, or ultrasounds, to look into the clubfoot, they also generally will look at the hips, because with club feet is a risk of hip dysplasia. So generally, they do serial casting. What that means is every week the foot is turned a little bit more and a new cast is applied. It generally can go on for 6 weeks or so, depending on the physician. And many times this is very successful. When it's not successful, at 3 months or so, surgery is done, and they cut the joint and tendons and manipulate the foot and put a pin in the bone to keep the foot in normal position. And then they'll repeat the casting again. Whether the casting is successful or not, when all the casting is completed, the baby is put into what's called a Dennis Brown bar with special orthopedic shoes, and that will actually hold the feet in position so that it doesn't revert back to uteral state. So this is on usually for a while, for 24 hours, and eventually they start weaning the children out of it, where they only have to do it like 10 hours a day and then 6 hours a day. Sometimes the physician suggests that they just do it when the baby's napping, when they really relax their feet. And within a year, the child usually has pretty nice looking feet. Nursing care would be one of the problems when any of the kids have any kind of disorder. Parents are really focused on that disorder and forget about other issues. So it's important to teach them to hold, cuddle, and try to help the baby along with its development. If the baby has casts and it's going home, we need to teach the parents how to take care of the casts to keep them dry, because they're usually plaster of Paris casts in this situation, and how to check the neural status of the feet to make sure there's circulation, and look at the toes and the thigh where the cast ends to make sure that the cast isn't rubbing the skin. The parents need to be encouraged to keep their regular appointment for their cast changes or brace changes. Like I said, it's done usually weekly, and the foot is manipulated more and more till eventually the foot is straight again. But it needs to be done weekly. So the next one is developmental hip dysplasia, or DDH. And there's 3 different kinds of hip dysplasia. There's acetabular dysplasia, there is subluxation and dislocation. And remember that in our hip, the socket can be shallow, and it can be very shallow, and therefore the femoral head can slip in and out, and that's what causes hip dysplasia. The femoral head is not secured in this the actual socket, so it can either slip in and out, it could slip downward, or slip out and stay out. That's the dislocation. The contributing factors is generally there's a family history of hip dysplasia. Gender, it tends to be the firstborn girl that is at most risk for this. The intrauterine position is really one of the biggest problems. The firstborn, particularly, the uterus hasn't been used before, and it's a little bit smaller for the first time. So the position of the baby might be cramped. Also, with multiple births, the position of one of the babies may be cramped. A baby that's breech may be positioned incorrectly. Of course, it is positioned incorrectly, but it may cause the hip dysplasia. A large baby may cause a hip dysplasia. The hormones from the mother can cause laxity of that joint, so that joint is kind of like, I can't even think of a word that would make it like easier to come in and out, the femoral head to come in and out. Again, it could be genetic factors. We see this at 3 different times. The congenital hip dysplasia, of course, is the newborn, and it's usually picked up somewhere between 1 and 2 weeks old, generally speaking. Then there's the infant, which is late infancy into toddlerhood, where it may have just occurred, and later, just as a child, it could just occur without rhyme or reason. So for the newborn, we'll see asymmetry of their gluteal and thigh folds. So the first thing we will do is lay them prone and look in the back and look at their gluteal fold and see if one is higher than the other. Turn the child over and put them supine. Pull their knees up to their chest and look at their knees. Generally speaking, one knee will be higher than the other if the child has hip dysplasia, and that's called the Gazalzi sign. One thing we do when we do all of our checkups is a Ortolani and a Barlow test. With the Ortolani, we put the majority of our hand on the greater trochanter of the baby, and our thumb will go on the inner thigh. We will actually try to do what we call frog legs with the baby. So we pull the thigh and hip up a little and out, and we will feel a clunk, and that's what it's technically called, a clunk. Then we'll do the Barlow, which will be returning it, so we displace the hips, and it shouldn't be that easy to displace the baby's hips. So we move our thumbs just a little bit more on top of the thighs, and we push down and in for the Barlow, and as we get close to adduction, we'll feel another clunk as we reduce the issue. So a baby with developmental hip dysplasia will have a positive Ortolani and positive Barlow test with, and they'll have limited hip abduction. They have a hard time. They have stiff hips, I guess is a good word to say. The Ortolani and the Barlow is generally done until the end of the 3rd month. And then after that, it's pretty inaccurate. You're going to be getting the clicking instead of the clucking, which is somewhat normal. So after 4 months or so, the child needs to be x-rayed to see if they have hip dysplasia. Usually, if you find this positive ortolani and Barlow, an ultrasound will be ordered. For an older child, you'll note that one of the legs is shorter than the other. The child will walk with a limp, or with one foot, they'll walk on their toes. We'll do a Trendelenburg test, where we'll have the child stand straight and then pull up one knee, like flex up one knee. We usually want them to flex up the knee, that's the shorter one. With that, we'll notice that the pelvis kind of tilts downward. It won't do that if the child does not have hip dysplasia, but if it does, the wall now is weak and the hip will go and tilt downward. And that would be a positive Trendelenburg sign. So diagnostic procedures will be, if we hear the clunk, at 2 weeks an ultrasound will be done. And at 4 months and older, we have to do x-rays. Initially, the child will be put, if they're under 6 months, in a Pavlik harness. This harness is put on by the orthopedic doctor. The child's measured, it's put on, and it has straps. And what it does is it keeps the hip in the head of the femur and the ball into the socket. Every week to 2 weeks, the child will need to go back to the orthopedic doctor and have the straps on the brace adjusted with the child's growth. They'll also look at the skin to be sure, the skin isn't being rubbed raw. The child generally will be in this for anywhere from 3 to 6 months. When they take the child out, if the hips appear to be in place, the child will be fine. If the hips are not in place, the child will be temporarily put in Bryant's traction, which is a skin traction, and they will have surgery. If the child is under 2 years old, it's generally a closed reduction surgery. If the child is older, it'll be an open surgery or an osteotomy. Post-operatively, those children will be put in a hip spica cast. So if you look on the next slide, the first picture is someone doing the ortolani test with their hands on the greater trochanter and their thumbs on the inside of the thigh, pushing up and out. And then the Barlow, you see that they moved their thumbs just a little bit, and it's down and in. The Pavlik harness is in the next picture. It shows you front and back, and this is exactly what it looks like. This child should have a t-shirt on so it's not rubbing him. The hip spica cast. The hip spica cast has what we call pedaling, P-E-D-E-L-I-N-G, around the genital area and where the cast ends on the legs. And that is for 2 reasons. Number one, it's to keep the ends of the cast from rubbing on the skin and causing irritation. And in the genital area, these are waterproof tapes that are put on. So if the the urine isn't caught in the diaper, or the stool's not caught in the diaper, these tapes will prevent the cast from getting soiled. And last but not least, a picture of Brian's traction. The child is put in skin traction, Brian's traction. His buttocks is at the very end of the bed, and he's kind of held in place there. His feet are straight up with his knees slightly bent, and the ropes go straight up and down over, and there'll be a little weight on those end of those ropes to hold the child in place. Nursing care. Okay, in general, for any kind of procedure this child has, once again, is we have to promote growth and development and encourage holding of the child. For the padlock, we have to maintain the harness placement and teach the parents to do the same. The straps need to be checked every 1 to 2 weeks by the orthopedic nurse and adjusted for growing. The child needs to wear a cotton t-shirt under it. For Brian traction, we have to maintain alignment and make sure his little buttocks stays at the end of the bed. We have to do frequent neurovascular checks, skin integrity checks, and for pain. Maintain traction and make sure the weight is not on the floor. For the hip spica cast, it is actually changed frequently to accommodate growth. And one thing I didn't mention is if the child is diagnosed at 4 or 5 months with hip dysplasia, like they weren't diagnosed in the beginning, generally they'll just be put in the hip spica cast and see if that will correct the situation. When the child comes back with the cast on, the cast will actually be positioned on a pillow, and so that a little bit of air can get up to the back of the cast. Remember, with the wet cast, you use the palms of your hands to move the child. You want to turn position and do range of motion on the unaffected extremities, monitor nutrition and hydration, and provide that waterproof barrier. You'll teach the parents, if the child goes home with the padlock harness, that it needs to be on all the time except for bath time. So approximately 23 hours a day, every day. They need to keep their weekly visits. Eventually, they'll be less frequently. You can explain the complications of, the padlock harness or the hipocast rubbing against the skin and causing skin tears, and that they need to monitor and report it. Also, they need to take a look at the neurovascular checks on the child frequently, and they need to be able to meet the child's developmental needs. The nurse will help with social services, providing appropriate equipment for discharge, such as a large wagon, a special car seat, a special stroller. So scoliosis is a lateral curvature of the spine, and you'll see spinal rotation that causes the ribs to be asymmetric. There's 2 different kinds of curves. One's an S and one's a C, and the literature says the S is probably the worst of the 2. It can be idiopathic, or it could be structural and seen with other conditions. You'll see that the scapula or the ribs or the flanks, shoulders, and hips are asymmetrical. When you look at the child, you'll see that his clothes are ill-fitting, with one leg appearing shorter than the other. The risk factors, of course, are genetic, but it's more common in girls and boys, and it's noted between ages 8 and 15. The nurse does the first diagnostic procedure. It's called the Allen's bending test. And generally the kids will be in, the boys will just be in shorts, and the girls will be in shorts, and they'll have to pull their top up a little. They sometimes will screen these kids in their underwear. The child bends over at the waist and hangs their arms down. The nurse is behind the child, and they look to see if they can notice if the hips or the ribs appear uneven. If so, the second diagnostic procedure is done. They will put one of these scoliometers that it shows on the bottom on the spine to get kind of an estimate of the degree that the child, is at risk for. From there, they'll go to X-ray for the Cobb technique, which will measure the degree of the curve, and the Ricer scale to determine if there's skeletal maturity. What they try to determine, especially with girls, is they mature, some mature very young compared to others. So if the curvature is 25 degrees or less, and it shows that they have skeletal maturity, generally it's not going to get any worse. But if it shows like an immature skeletal area, and they're already at 45 degrees, the child will definitely be, put in a brace, and surgery will be discussed for the future. So the first picture on this page is the Allen's bending test, and the nurse would be behind this child. And you can see that the last picture that her scapula looks like it's risen above. The second picture is a picture of the cab test, and it shows you the different angles that are measured. And then the third is information about the Reiser test, which is another x-ray procedure. So when the child is first diagnosed, if their degree is under 45 and they're young, it's considered moderate. So they'll actually put the child in a brace, and it needs to be on, again, they want it on 24/7, but the child could have it off for showering, but they need to sleep in it as well. There's a couple different braces. There's a Milwaukee brace, which is probably what I'm showing you here, probably the most common one used. And this will not cure the scoliosis. It will not improve it, but it will allow it not to get worse. It'll keep it at this stage. So as the child matures, if we can keep the degree low, they will not need surgery. But the child needs to wear the brace all the time, which is usually the problem, with their body image at this age. If it certainly could continue to get worse on its own, even if the child wears the brace. However, the thought is it probably won't, and this is all the child might need to do for a couple of years. So the child will go for surgery if the angle is 45 degrees or more. And the pre-op nursing care will be, of course, to look over all the labs, to do preoperative teaching, prepare them for what they're going to see post-op, especially like the Foley catheter is usually frightening, and the PCA pump, they need to learn about it. They also need to learn about coughing and deep breathing and incentive spirometer. They should be taught that they will be doing log rolling and not bending, so it's not a big surprise. And generally, preoperatively, the child gets their own blood drawn so they can do their own blood donation. The picture at the bottom is a spinal fusion with the Harrington rod supporting the spine. Postoperatively, the child will be monitored for pain using the pain scales. You'll have to re-explain how to use the PCA. Frequent neurovascular checks with vital signs are generally done at least every 2 hours, and log rolling will be about every 2 hours. Skin care and wound care and drain care will all be performed every 2 hours. Coughing and deep breathing and using the incentive spirometer, and the nurse will need to monitor for infection. She'll monitor for bowel sounds, and make sure the tummy's awake before we feed the child. And we want to watch for a paralytic ileus, because of a spinal surgery, it affects the abdomen as well, the abdomen and lungs. The labs will be monitored, and almost always these children need blood administration. Spinal surgery is kind of it's kind of a given that they'll have to have blood transfused. Range of motion will be done by physical therapy to get the child moving. And remember, this is an adolescent, so appropriate activities for their development is very, very important. So discharge education to the patient and the parents is the child usually is in the hospital for 2 or 3 days. Number one, we want to make sure that wound is starting to heal. We want to see them moving around. We want to keep an eye on their neurovascs, but we also want to keep an eye on their breathing, because lung complications is probably, it's really, they're at risk for lung problems postoperatively. They need to know they have to continue PT. They need to be taught the signs and symptoms of infection and complications, and they need to be reminded that they need regular follow-up care. The complications can be the breathing issues. They could possibly have nerve or spine damage. infection following surgery is very common. And lastly, but not leastly, it's very important to keep an eye out for that child's self-esteem issues. Osteomyelitis is an infection in the bone, and it's generally seen in long bones, but it can be seen in joints as well. It's usually from a bacterial infection, from an outside source. Very rarely is osteomyelitis like from an old strep throat going somewhere else or something else. It also can be from a fungus. The most common infection is staph infection, Staph aureus. The child will present very ill and irritable. They will have a fever, and wherever you have a fever, you have tachycardia. The place where the osteomyelitis or the infection is will be warm and swollen and painful. They won't want to use that extremity, and the pain worsens with movement. So it can be from anything, it can be from stepping on a needle. It can be from a bad injection. It can be from a open fracture in the past. And sometimes they get a thorn stuck in them. It doesn't come out and it travels to the bone. So it can be from almost anything. The nursing care for these children is to assist with all the diagnostic procedures. Generally, they do a bone scan. The child will usually go for either a port or a line, like a Hickman catheter. So they'll go to surgery, and then they'll begin IV antibiotics for 6 weeks. They're generally only in the hospital until their IV site heals. The area needs to be immobilized, and the extremity needs to be elevated, and many times they put ice packs on it. The child will get pain medications. They usually go home in 3 or 4 days post-op, and the family needs to be educated on immobilizing the extremities, signs and symptoms of a worsening infection, and how important it is to complete the antibiotic and the care that the port needs. Leg calf perthes, you might also hear it called leg perthes, is where for no really known reason the femoral head becomes necrotic, and nobody knows why. The symptoms, unfortunately, are so similar to growing pains that it usually goes for a while before they seek treatment. The child begins with intermittent painless limp. Doesn't hurt, and it's here and there. Well, they say it's painless. It must bother them somewhat. They have shortening of that leg, and eventually the painless limp turns into hip, thigh, and knee pain. And it worsens when they're moving around, and rest will relieve the pain. The child will complain of hip stiffness. They will have a limited range of motion, and if it goes on too long, they'll begin to see muscle wasting. So nursing care for a child with leg calf perthes disease is we promote limited weight bearing. So we really don't want them, walking and limping. They'll either be given crutches or be put on bed rest for a while it heals. They'll get NSAIDs for pain, and many times they are given a brace or a cast retraction for it. Physical therapy will visit them and give them exercises. If it's mild, the patient will go home, and the parents will know that when they complain of pain, they need to rest. They need to have their NSAIDs, and they need to wear their brace. However, worsening symptoms would be weakness and muscle wasting more, and more shortening of the affected limb requires surgery, and it's an osteotomy of the hip. So osteogenesis imperfecta. This is kind of known as the brittle bone disease. and it's an inherited disease that results in brittle bones and poor growth. Sometimes it's known at birth that the baby has this, especially if there had been genetic testing and the parents are aware that they pass this on. But other times we don't know until the child has their so-called first fracture, and then looking upon the x-rays you can see that there's been multiple fractures. Poor growth means that these children are very short, very, very short, and actually their teeth don't grow. They keep their baby teeth and they get kind of brown and discolored. They have multiple fractures. The sclera of their eyes is generally blue, and it's a slow progressive hearing loss, and they end up with hearing aids. Nursing care, we can give one medication called pamidronate, and there are some adverse reactions for it. First of all, it affects the liver, so liver studies have to be done frequently. But second of all, it actually washes a lot of the minerals out of the body because it uses those minerals to strengthen the bones itself. The medication absorbs it and puts it on top of the bone. Therefore, trying to strengthen the bone, the risks are that the child will actually decrease his minerals. The other thing is thrombosis. Because of this drug interfering with the inside of the bone, it also interferes with the bone marrow. So we see the clotting factors affected. For pain, the child can be braced or have splint care. However, many times they are in a wheelchair. The child can have low impact exercises. Physical therapy will help them with that. But really they can't do a lot of sports or ballistic things. Swimming is usually okay. And it's important as the nurse that you find out other likes of the other child that could be done, like crafts and music, things that could be done that won't hurt the child. The parents need to also be taught about the medication. And because of this medication, the child will need antibiotics prior, dental visits, or any invasive treatments. Amen. Juvenile idiopathic arthritis, JIA, used to be called JRA, juvenile rheumatoid arthritis. But they found that with children, for some reason, the rheumatoid factor is negative. So to call it that was kind of confusing to the public. So instead, because we don't know why children get this, it's idiopathic, they decided to change the name. It's a chronic autoimmune inflammatory disease that affects joints and tissues. It's not contagious, and there are 6 subtypes. And I wrote them down here and what joints they affect. We're going to talk about it in general, juvenile idiopathic arthritis. The child, actually, fever should be first. The child presents first with a fever that goes up and down but never really goes away, and then he begins with joint swelling and pain. What does that sound like to you? Maybe a little bit like acute lymphocytic leukemia. Same symptoms actually to start with. But with these kids, the joint starts to swell, they get stiff, and they're warm. It's always worse in the morning or after they're sitting still for any period of time in activity. The fever is always present, and eventually they start having problems walking or reaching for things or using their hands. They usually develop a rash, and when they start getting up in the morning, if this goes undetected, they start limping. The pain is severe at that point in the joints, and they start limping. We also see a delayed growth in these children. Is it from the disease, or is it from some of the medications we put them on? Who knows? Lab work will show an elevated C-reactive protein, elevated WBCs. The anti-nuclear antibody usually is positive. It certainly can be negative because this particular disease doesn't show up in the blood work like it does with adults. And then the rheumatory factor is negative. So to take care of these kids, the diagnosis usually is made based on symptoms and the little bit of blood work they have. So for pain at first, they'll give them NSAIDs, and the child needs to take them with food because it usually irritates their stomach, so they shouldn't take it independently. Many times kids for a while will take this twice a day. Then they start them on the DMARDs, and methotrexate is given with another biological. And generally the one for arthritis is Antaresept, which the other name for that is Enbrel. You might notice that. Sometimes the kids are given Humira instead. It just depends. But the reason for these drugs is it slows down the process of joint deformity and pain. So they're given as a team. The methotrexate is sometimes daily, sometimes it's once a week, but the Enbrel is usually once a week. It does affect liver function, so liver function tests have to be given. And unfortunately, one of the side effects is a development of lymphoma. So the child needs a CBC constantly done as well. Usually it's done every 6 weeks. When they have an inflammatory process going on and they're in severe pain, they will give some kind of steroids. If the child's a little bit older, they can have, the prednisone tablet. It's nice and small. If not, the prednisolone or the Prelone liquid will be given, but only during the painful episodes, which are called exacerbations. Complications of having this disease is permanent joint deformity and functional disability. Sometimes it's so severe these kids end up in wheelchairs. Uveitis sometimes also happens. It depends on the medications they're on and exactly which JIA is affecting the child. So the nursing care, if you get a child in, will be to put warm packs to their painful joints, and sometimes warm baths for the little kids is really good. They need range of motion. They need to keep active. Physical therapy needs to see them, but they also need to learn relaxation techniques for when they're in pain. This has been proven to help children. Pain medications will be ordered, and the family needs to be educated on the pain medications and the other medications that they are on. They need to get their lab work done regularly, and parents can't miss that. The child needs a well-balanced diet because we don't want them to get too heavy for their joints. And unfortunately, we need to teach parents that exacerbations worsen with illness. The child needs to be allowed to do as much as possible for themselves. So they might start depending on the nurses or the families, but it's important to encourage the child to do things for themselves. And if they do get the uveitis, they need to get some steroid drops. Now we're going to talk about traction, skin traction and skeletal traction. And you need to remember that there's 3 purposes for giving or applying traction for a child. We want to align the fractured limb or body part and prep for casting, splinting, or surgical stability. We want to reduce the fatigue of the muscle groups and alleviate any tremors or spasms. And we want to mobilize fractures and place bones together to allow them to heal. So there's 3 types of force. There's a forward pulling force that may be used to reduce the dislocation of a fracture and realign the 2 sides. There's a counter force, which is a backward pull, that will use the child's weight as an anchor. And then there's a frictional force that established as the child's body on the bed surface contributes to the stabilization of the traction. So skin traction is actually, they'll have some kind of a wrap on their skin, And the weight is actually applied to this wrap or to the boot that they put on the child. And it pulls in the right direction using a pulley system attached to the hospital bed. It's used a lot for soft tissues, muscles and tendons that need to be repaired to get them, relaxed and in the right position. Skin traction is usually not the only thing that's done. It's usually done in preparation for surgery. Skeletal traction is where wires and pins and screws and tongs have been placed surgically at the distal end of the bones to apply direct pull to the bone. Weights are attached to the pins and wires, as you can see in this picture, that causes for stability for the fragmented fractures. And then the halo traction, where the screws are inserted in the outer skull. There's two types of halo tractions, one where the patient's in bed, and the halo traction is attached to the bed, or there's another halo traction that's secured to a vest so the patient can get up and walk around. With halo tractions, it's important to make sure the pins don't loosen and monitor for signs of infection. But what's even more important is that there's a wrench that needs to either be at the bedside if the patient's in bed, or it needs to be attached to their vest if they're walking around, so that if one needs to get that halo off the patient in a hurry, the wrench is available. That would be maybe if CPR is needed or the patient goes into respiratory distress. When they are in halo traction, you need to move them as a whole unit without applying pressure to the pins. Nursing care for tractions is remember to keep the body in alignment. Remember when we did the Brian's traction a little earlier, I showed you that the bottom, their butt, is right at the end of the bed. It needs to stay there. And, so the patient shouldn't scooch up higher or actually lower. So they need to be in alignment. They can be repositioned when they have pain at first to see if that's the problem, but be sure to give pain meds if needed, and always there'll be an order for something for muscle spasms. Frequently check their neurovasculars and check their skin integrity. Make sure that if pin care is ordered that you do it, and always check the hardware to be sure that it's tight. Make sure when you walk into the room that the weights are hanging freely and they're not on the floor or on the bed. Monitor for signs of infection at the pin site, which will be drainage and redness and swelling. Children that are in traction need an over-the-bed trapeze so that they can move around and do not put so much strain on the nurses. Range of motion is done generally for the other extremities. And because the child's going to be in bed for a while, cough and deep breathing is really important. It's important to prevent constipation as well. So generally you need to ask for a stool softener or do high fiber foods. If you make the bed, move the sheets from the top to the bottom and work downward, not from side to side. And once again, if they're in halo traction, that wrench needs to be with the client at all times. We'll talk a little bit about fractures, and what I want you to know is actually what I'm going to just tell you. And it's very, very simple. In this picture, you'll see complete and incomplete fractures. So complete fractures is where the bone is broken all the way through. And incomplete fractures is where it is just cracked or slightly broken. So, and you can see the difference, like the oblique is a complete fracture, where let me find one here. There's a stress fracture or a green stick fracture. Those are incompletes. Simple and compound is the first picture. The simple shows that there is a fracture all the way through, but it's not displaced. It stays right there. It's straight through. Put in alignment, it should heal by itself. Compound fracture, generally, the bones are displaced, and many times it will be an open fracture where it goes through the skin. A plastic fracture. A plastic fracture, I wrote a little note on, let me just find it. Can't find it right now. The bone is bent, but no more than 45 degrees. It's just bent. So a buccal fracture, interesting enough, a buccal fracture usually occurs when the child's trying to stop his fall and he puts down his hands, and unfortunately it jams the bone into the wrist and it fractures. There's some epiphyseal fractures that show you right by the head of the bone. And then complicated fractures is where the bones are broken, but it impedes on either the tissue, the nerves, the blood vessels, or another organ. And this picture shows the ribs are fractured and they are impeding on the lungs. And then on the bottom, very, very small, is a closed fracture, which doesn't penetrate through the skin, but an open fracture does. So the risk factors for fractures is poor nutrition, usually decrease in calcium and minerals will make the bones a little bit more brittle. Obesity, too much of the fat pads, we think will protect our bones, but actually it's too much weight in an area. Sometimes developmental kids, just running, being clumsy, they can't control their body so much. And then there's the older child that's in sports that gets hurt accidentally. Sometimes thyroid problems or other metabolic disorders will affect the calcium level and set the patient up for fractures. Sometimes lupus and other inflammatory diseases, swelling at the joints, can actually leave the rest of the joints where they could be rest of the bones, easily fractured. And then kidney disease, distributing the protein and the minerals, from the body. You'll see pain. If you feel and listen carefully, you can hear crepitus or feel the crepitus. The child will not want to use that extremity, and there will be ecchymosis right at the site. You will also feel warm and red, and sometimes there's actually a deformity. You can actually see something, wrong. And most of the time the area will swell up. So when a child comes in with a fracture, the nursing care, the first and most important thing is paying close attention to their neurovascular checks. It can tell you an awful lot. It's sensation. If the child says they don't feel you touching them, or if they complain of pain, pins and needles, it needs to be documented and reported. Skin temperature. Where the fracture is, the skin temperature is usually warm. Capillary refill should be under 3 seconds. Movement. They usually won't want to move the area, and you want to actually help them not move that area until it's either braced, casted, or surgery has been performed. You're going to check the pulses frequently, and you're going to do a pain assessment. When they come through the ER, no matter what kind of a fracture it is, make sure that the fracture, first of all the people that accompany the patient have the same story about how this fracture happened. And it has to be verbatim. The second thing is to make sure that the story is consistent with the type of fracture. For instance, I put an example. A typical fall off a swing can produce a buccal or green stick fracture, but does not typically produce a spiral fracture. So a green stick fracture is where the bone looks like, let me see how I could put it, like a little tree, and it's a little bit cracked. The branch is a little bit cracked, like it's going to come off, like a little branch is going to come off the tree. Where a buccal fracture, usually is from putting your hands down to protect yourself and you fracture your wrist. A spiral fracture is usually done when an extremity has been twisted. So spiral fractures almost always are a form of child abuse. Green stick can possibly be, but not always. So make sure when they say that he fell down 2 stairs that he doesn't have, a whole body fracture as if he fell down 20 stairs. Make sure the story fits the problem. There's basically 2 types of casts that are used this day. And the plaster of the Paris cast is the oldest. It's heavy. It's not water resistant, so that's negative. And unfortunately, it takes a long time to dry. And the child needs to be turned frequently so that air can get at it. And remember, you use the palm of your hands so that you don't puncture a hole in it. The good thing about it is the material can be molded. So generally, it's the material of choice for many other deformities, such as the club foot or the hip spica cast, for the hip dysplasia. It can be molded and it truly will hold that area in place and won't let it move at all. The fiberglass cast is really nice. It's lightweight, it's water resistant, and it dries really quickly once it's put on. The material is rigid, so it's pretty good for most fractures. But it's good for fractures because it's rigid. You can't mold it to a deformity and hold that deformity in place. It just doesn't work. So nursing care is to assess and monitor their neurovasculars once they have that cast on. When they come back from casting, make sure that you elevate the cast above the level of the heart for 24 to 48 hours to prevent swelling. Ice is applied for the first 24 hours, on for 20 minutes, off for 20 minutes. The child needs to be turned frequently, every 2 hours as suggested. We keep the affected extremities supportive and assess for increased warmth or hot spots. You'll actually feel the warmth or hot spot in a cast if it's rubbing the skin and causing an infection. Also, it'll smell. Monitor for drainage and assess the skin. Wherever you could see the skin come in contact with the cast, make sure it's not rubbing. Remember, if the cast is still wet, to use the palm of your hands. You can put moleskin all over the entry and exit of the cast, I guess you could call it, where it's open on the skin to prevent friction rub. And if it's like a hip spica, cover areas to prevent soiling from feces. Many times the patient will be in the ER for a while, get their cast, and then they'll need to learn how to walk on crutches, and they'll need to be fitted for crutches. Elevate the extremity when they're sitting down. And when it comes time for cast removal, the client should soak off the excess cast material and apply lotion. They shouldn't pick it off. They can actually pick off their skin with it. They should soak it off and apply lotion to heal. I know many of you know about compartment fractures, and it's where the cast gets so tight it compresses the nerves and blood vessels and muscles. And if it isn't detected pretty quickly, the area could become necrotic. So the symptoms for this is the 5 P's, and some book has 6 P's, and I'll explain that. But the first P is pain without relief. So patient tells you they're in severe pain, and they have pain meds ordered, and you give it to them, and then when you check with them about 15-20 minutes later, the pain has not been relieved at all. You need to be suspicious. You check for paresthesia or numbness of whatever it is. Like if it's the arm, you'll check and see if they have numbness in their arm and hands. You'll check their pulses to see that they're not having pulselessness distal to the fracture. And you'll check to see if they can move their digits if it's in the arms or the toes or the legs. Paralysis is the 4th P, if they cannot move their digits. And last but not least, pallor. If you don't even have to check for blanching because it's already so white, when you touch it, it doesn't change. If there was a 6P, it was a funny word, and it begins with a P, but what it means is like warm areas. It isn't a technical term that's used that often, and so the 5 Ps is really what orthopedic nurses use when they're looking for a compartment syndrome, and you should know them. Okay, last but not least, spinal bifida is the failure of the osseous spine to close. There's 3 different kinds of spinal bifida, and they're actually considered a neurotubal defect. And they're present at birth. They can be seen during pregnancy on the ultrasound, and they're definitely going to be seen when the baby's born. Some of these neurotubal defects are operated on in utero, but not all of them. Some contributing factors can be some of the medications that mom needs to take during her pregnancy. Sometimes they are the seizure drugs. Or if the mom is using substances during her pregnancy, or if she is not eating correctly and is malnourished. About 30 years ago or so, they did a study on women that had babies that had spina bifida, and what they found was they had a insufficient intake of folic acid. So at that point, it became known that this was the problem. So all pregnant women are given a prescription of folic acid to take during their pregnancy. If mom's exposed to radiation or chemicals during the pregnancy, it can be genetic, it could run in their family. And it also could be the presence of other congenital abnormalities, and this just tacked itself right onto it, which happens many. So as I said, there's 3 types. And the first type is the most mild. This is the spinal bifida colta. And you actually might not know somebody has this. It might be detected later. And actually, the little tiny sac is right inside the skin, so you may not see it. The meningeal seal is a protrusion of the spine, and it will have a sac, but only cerebral spinal fluid will be in it. And last but not least, the most serious, the myelomeningeal seal, will also have that sac, but unfortunately it has spinal fluid, meninges, and nerves or neural tissue inside. The most mildest is the spinal bifida colta, and it's not obvious if a child has this. The protruding sac is not visible, and it only involves a little tiny portion of the spine, and usually the book calls it dimpling in the lumbosacral area, where you might see a rectal cleft or a rectal dimple. That is where the spinal bifida colta occurs. And when a baby is born, some babies, it's a family trait. Some babies have that rectal dimple. So you need to get a flashlight and look inside that dimple and make sure that there is skin, there's a bottom to it. If you can't see it, chances are it may be a spinal bifida colta. Sometimes these kids will have either a port wine angioma there, or they might have a hemangioma there at the same place, and they usually will have dark tufts of hair and maybe a subcutaneous lymphoma. If we find that anywhere in the back area, we start looking for a spinal bifida colta actually. Many times this goes undetected until the child tries to potty train, and because of right where it is, sometimes it affects their bowels and bladders and they don't have that muscle tone. Other times the children, when they walk, they have like a waddle when they walk. The last time is when a growth spurt of adolescence begins. The nerves of the spinal cords begin to stretch, and this results in some weakness and numbness in the legs, sometimes bladder infections and incontinence due to the stretching of the nerves, and that's in the adolescent age group. Meningeal is the second one that's not as common and it's not as serious. So there's a protrusion through the opening of the spine, and it causes a little sac on the back, on their back. They're usually repaired through surgery, and there's no nerve damage, and the child develops normally, and there's no other neurological or orthopedic problems. However, the worst of the three is the myelomeningeal seal, and it's the most severe form, and it occurs in 1 out of every 1,000 live births. The portion of the undeveloped cord protrudes through the back. There's a large sac that contains cerebrospinal fluid, meningeal nerves. The blood vessels surrounding the protruding cord, which is usually not covered by skin, so that the nerves and tissues are now exposed. A large portion of the infants born with this also are born with hydrocephalus due to there's a defect at the base of the skull called the Chiari malformation. And this little picture kind of shows it to you. It's right at the brainstem. Okay. Infants born with myelomeningeal seal generally will have paralysis or weakness below the level of the spinal lesion. It almost always affects the lower limbs, along with problems with bladder and bowel functions. This is in extreme cases, the trunk and upper extremities are involved. But how you will know that is the protruding sac, the higher the sac or the higher the lesion, the more of the body will be involved. So if it's higher up on the back, chances are the child will be a quadriplegic. If it's very high up, they will end up trached in, a lot of times on a vent as well. They'll have the protruding sac midline, and then the defects depend on where the lesion is. We always see flaccid paralysis of legs, and there's no sensation in their legs or reflexes or spasticity. So we have to be careful that, number one, they don't get sunburned because they won't feel it. Number two, that you don't push them like up against a radiator when they're in their wheelchair because they won't feel it. A heating pad could be dangerous to this kind of a child. They have no feeling in their legs. So wherever the lesion is, whatever's affected, there'll be sensory deficits. They generally are urinary incontinent and bowel incontinent. They have a prolapsed rectum. They may have clubfoot. Kyphosis is very common, so is scoliosis actually, and hip dislocations. Prenatally, the lesion can be seen in an ultrasound, and the diagnosis can be made through an amniocentesis. However, after birth, an MRI, ultrasound, and CT can make the diagnosis. When the baby is born, usually within 24 hours, they have a surgical repair. Collaboration needs to be done with all these different departments listed here to give the child the best treatment. The nursing care for the baby preoperatively, so the baby's born and will be placed naked in a prone in a warmer with their hips flexed and their legs abducted. The sac will be present, so you want to protect it with the sterile, moist, non-adhering gauze over the sac, and it needs to be changed every 2 hours. Generally, they'll use normal saline for this. Their neural status must be measured frequently, and it includes checking on their cry, their suck, their head circumference, sensory fontanelles, and movement. You inspect the sac for leaks, irritations, or signs of infection. Through an INO and IV antibiotics. No rectal temperatures because of the rectal prolapse. No diapering. We don't want anything over that sac or anything that would cause stool to get near that sac and infect it. As difficult as it is, you need to promote parent and child bonding. Some of the children, the only thing that looks funny is the little sac on their back, but other children will also have the hydrocephaly and not look so good to the parent. And it's only natural to love your baby no matter what, but sometimes you have to help the parents They can't even hold the baby at this point, and the baby will be NPO waiting for surgery. Postoperatively, when the baby comes back, again in a prone position, and the neurals need to be watched closely, as does the incision site for leakage, redness, and irritation. The baby will be on INO, and when the prescription comes, you can resume oral feedings. Intermittent straight catheterization needs to be done because they'll have no bladder control. And pain medication, they can't tell you. You'll have to use the flax scale and range of motion on whatever extremities you can do it on. Complications for the surgery, generally skin ulcerations is very common. These children tend to have latex allergies. It's just a #1 thing with them. Increased intracranial pressure may happen, and if they have a shunt, you have to watch for malfunctioning and infection. You'll have to look for bladder dysfunction, neurogenic bladder, because they can't, the urine is just going to sit there and it's going to get infected. And they may have other orthopedic issues. And I'll tell you, kyphosis or scoliosis is very common. Baby will be getting ready to go home after the surgical procedure heals up. And you'll need to help the parents and social services get whatever medical equipment, and you can suggest things that might be helpful to them. You'll need to sit down and teach the parents what normal growth and development is like and what they can do to help that. Range of motion, what medications the child goes home on, and skin care, especially for wound care, should be on there with that lesion. The parents need to be told of the risk of latex allergies and given a list of items that contain latex. They need to be taught how to measure the head and palpate the fontanelle for edema. They need to know about the signs of increased intracranial pressure and the signs of bladder dysfunction. They need to be taught how to do intermittent catheterization. It doesn't look like it's spelled right. They need to be taught shunt care, splint, cast, and stoma care. They need to be taught shunt malfunction and infection signs. And they also need to be taught how to protect that incision from injury by keeping the child prone or sideline until the physician instructs otherwise. The end. See you in class.